Hi students, good evening. Good evening everyone. So I'm Dr. Sanjeev Chitragar. So let's look at pathology recall session of this August 2025 NEET PG, right? Hi guys, hi, good evening everyone. Hi students, good evening. Good evening everyone. Okay, in pathology you got all correct, Krishna Agarwal. Yep, so I'm so happy to get feedback from you that all questions were correct from pathology. Okay, let me start with first question. Pathology has a patient has presented with history of cough, respiratory discomfort for 1 month. So they had given history of 1 month is there, and there is hilar lymphadenopathy. Biopsy shows granulomas with stellate inclusions. So there are stellate inclusions that are seen. Stellate inclusions are nothing but star-shaped. Stellate means star-shaped. What is a likely diagnosis? Star-shaped inclusion, we studied this in our, uh, systemic pathology as well. Inclusions. So stellate or star-shaped inclusions are nothing but asteroid bodies. Asteroid bodies are seen where? In sarcoidosis. That is a correct answer. Answer is option B here. Option B. Right? Yes. Next question. Histopathological examination of lymph node in a 50-year-old patient. This was given 50-year, shows neoplastic cells. I think they had given nodular pattern. Some people said me nodular pattern. So neoplastic cells in a nodular pattern, positive for CD10 and BCL2. So there were CD10 and BCL2 positive. Which of the following translocation is likely to be seen in this patient? So CD10 and BCL2 positive, this is your follicular lymphoma. And which translocation will be seen in follicular lymphoma? It is translocation 14-18, isn't it? 11-14 is for mantle cell lymphoma. Cyclin D1 will be produced. 11-18 will be marginal zone lymphoma. Marginal zone also can be BCL2 positive, but it will be negative for CD10. Remember this. And 8-14, 2-8, 8-14 and 8-22 seen in Burkitt lymphoma, right? I told you translocations are very, very important, with which we had discussed in the class, by the way, well in advance. We had discussed this in the class, right? Next is another question. Same question. This we have repeated so many times in the class test, grand test, class notes, TNDs, everywhere. Bone marrow aspirate of a patient having presenting with recurrent infection bleeding is as follows. Which translocation is likely to be seen? So the image showed multiple OR rods. I don't know whether exactly this was the image or different image, I'm sure. So multiple OR rods were seen. That is nothing but acute promyelocytic leukemia, which will show PML RARA translocation. We discussed this in the class. PML RARA is nothing but 15-17 translocation. Answer is option D. 15-17 translocation. Option D, isn't it? Yes. 821 will be seen in AML M2. Occasional or rods and granules will be seen. 922 is seen in CML or even in ALL as well. Inversion 16 is seen in AML M4 with eosinophilia. Right? Next. Question 4. So this was a patient diagnosed of depleted factor 9. This history was given. Patient was diagnosed. Depletion of factor 9 was given, right? Depleted factor 9. And the disease got corrected. So examiner told us the disease got corrected with injection of vitamin K. So with vitamin K injection, the disease has got corrected. That is what was given. What could be the likely etiology? This was the question asked. Yes, what could be the likely etiology? Hepatitis A, classical hemophilia, pernicious anemia, bile duct obstruction. See, remember, factor 9, vitamin K deficiency, it has got corrected, meaning what? So if it has got corrected with vitamin K, that means 2, 7, 9, 10, either of them. And anyway, they have given already one 9. It is not hepatitis. Why not hepatitis, guys? Tell me now. So if it was hepatitis, then what would have happened? Anybody? If it was hepatitis, then, yeah, hepatitis can cause depletion of 27910, but it will not get corrected with vitamin K. It has to be corrected after one resolution of hepatitis. That is not the answer. Hemophilia is not the answer because that is factor 9 deficiency. Pernicious will not have bleeding disorder. Pernicious will have megaloblastic anemia. Bile duct obstruction will lead to vitamin K deficiency because vitamin K is a fat soluble vitamin. So vitamin K deficiency could be due to fat malabsorption, whatever are the cause of fat malabsorptions, which will include bile duct obstruction. And also, other than that, will be excessive oral antibiotic because the gut flora is one of the important source of vitamin K. So, and in newborn also will have vitamin K deficiency, right? Next, this question we discussed a number of times in the class. A patient underwent a ileal resection, following which he developed anemia. Hemoglobin is 9 and MCV is, yes, MCV is 110. What is the likely etiology? Ileal resection, definitely nothing more to think about it. Answer is what? Iron deficiency, isn't it? Iron deficiency is the answer here. Not iron, ileal resection, sorry, B12 deficiency is the correct answer here, right? Yeah, we discussed it so many times. Iron deficiency, gastrectomy, iron deficiency, gastrectomy, duodenectomy will cause iron deficiency. B12 deficiency can be in ileectomy, even gastrectomy. Folate deficiency will be in jejunectomy, right? Sideroblastic, nothing to do with any of the sideroblastic will be porphyrin deficiency. It is not absorption problem, right? Yes, was LRR enough? Answer, yeah, LRR questions came from LRR. The problem is with LRR, your concept should have been there. Like, we did not directly discuss vitamin K deficiency with what? Bile duct obstruction in LRR. But we had discussed vitamin K deficiency, 9, 10, everything will be deficient. But this concept was discussed in actual class notes. Okay. So, where vitamin K deficiency will be due to fat malabsorption or excessive antibiotics or in newborn. So this question, we discussed this in LRR, by the way, even in DVT also we discussed. So most of the questions you would able to answer with LRR. This was able to be answered with LRR. This also with LRR. Okay. Yeah. Next question. Next, this was also answered with LRR alone. Child presented with fatigue, jaundice, splenomegaly. MCHC is increased. His father also has a similar history. So importance of yeah. Importance of this, father had a similar history. What is the importance of this? Father is having similar history. Father had a similar history. What is the most likely diagnosis? Means it is an autosomal dominant condition. Father is having similar history, autosomal dominant condition, isn't it? Yes. So what is the diagnosis? If it is autosomal dominant condition, diagnosis will be what? Hereditary spherocytosis. That is the correct answer. Hereditary spherocytosis, option D. Because thalassemia, sickle cell are autosomal recessive. AIHA is not inherited at all. It is an acquired condition, isn't it? Yes. Next, in which of the following uses caspase in its action? This was given. Again, we discussed this in class, LRR everywhere, DVT also. So, which of the following will have activation of caspases? Apoptosis, necroptosis? No. Necroptosis do not have caspase activation. Apoptosis, pyroptosis. Yes, that is the correct answer. Apoptosis and pyroptosis will be having. Apoptosis will have caspases 8, 9, 10, 3. Pyroptosis 1 and 11. Necrosis, no. Ferroptosis, no caspase activation, right? Yes. Next, histological examination. Question number 8. Histological examination. Yes, histological examination of tumor. Okay, so they had given, yeah, neck tumor. Neck tumor shows tumor cells positive for synaptophysin, chromogranin, and TTF1. So very important is synaptophysin, chromogranin positive, meaning what? Synaptophysin, chromogranin are positive. What does this tell me? This is telling me neuroendocrine origin. TTF1 positive. What does TTF1 positive tell you? Yes, TTF1. TTF1 positive will be thyroid or lung, but this is neck tumor they have given. So then means I'll think of thyroid. And there is amyloid material deposited in the tissue. So what is the likely diagnosis? We discussed this tumor amyloid can be seen in follicular thyroid carcinoma or insulinoma. Another one, multiple myeloma you can think of, right? So answer to this is medullary thyroid carcinoma. Medullary thyroid carcinoma. Will the cutoff be, will cutoff be more in this time? Answer is yes. This question came in FMG also, right? Next, question 9. Child presents with severe infection, decreased B and T cells. Both B and T cells are decreased means what? Combined immunodeficiencies, isn't it? Which are the combined immunodeficiencies we were talking discussed? SCID, SCID, then ataxia telangiectasia, and uh, your Wiskott-Aldrich syndrome. Decreased ADA. Again, we had discussed this in class, in DVT, and also in LRR as well. So decrease in ADA, adenosine deaminase deficiency, seen in SCID. SCID can be due to two conditions. What are the two conditions? One is interleukin 2 receptor mutation and one ADA. Interleukin 2 receptor mutation is most common. ADA deficiency is less common. And ADA is autosomal recessive. Interleukin 2 receptor is X-linked recessive. Brutons, no. Brutons will have only decrease in B cell, not decrease in T cell. Viscotaldric will have decrease in B and T cell, but will not have decrease ADA. In fact, Bruton will end up having what? Will have thrombocytopenia and eczema. That will be there in Bruton. And Dye-George syndrome, that is also not the answer. In Dye-George syndrome, both B and T cells will be what? Normally present. There is no maturation of, answer should be A here, right? There is no maturation of, what do you call, in Dye-George syndrome, there is no maturation of T cell happening, right? Yeah, answer is SCID, correct. Next, which of the following disease follows the pattern of the inheritance shown below? So in this pattern of inheritance, look at this, what you are seeing. In this pattern of inheritance, there is a disease happening where, so disease is there in mother. You can see disease in mother. From mother to all children, disease is getting transmitted. Mother to all children. But from father to none of the children. So I am not seeing any disease transmission from father to children. Father to children, again, father to children is not happening. So what is your diagnosis? This will be mitochondrial. So let me look at following will have a mitochondrial. Yes. Yeah, they had given this Kearns-Sayre syndrome, Williams syndrome, achondroplasia, Prader-Willi syndrome. Answer is option A. Option A. Yes. Next, there was one question. This is incompletely recalled. Okay, let me see. A patient in a protein which has 900 amino acid, there is a frame mutation. So there is a frame shift mutation at fourth amino acid, fourth nucleotide. Which of the following will happen? The moment there is a frame shift, original protein will not be produced and a new abnormal protein will be produced. We know that, isn't it? So no change in the protein. No, that is not the answer. This is not the answer. Protein will change, will get corrected by post-transcriptional modification. No, post-transcriptional modification will only change the first amino acid, right? Methionine. Change in protein, no disease. That is also not the case. Answer is option D. Complete loss of function of the protein and in fact gain of function of abnormal protein. Both will be happening in the due to same mutation. Both will be happening due to the same mutation here, right? Next, question 12. Cut section of a testicular tumor is gray white, homogeneous. So they had given without hemorrhage or necrosis. So they had given there is no hemorrhage or necrosis. And microscopy is as given below. What is a likely diagnosis? So they had given a microscopy as well. So look what you are seeing in microscopy here. So on microscopy, what am I seeing? On microscopy, I'm seeing fibrovascular septae. So I'm seeing these are your fibrovascular septae. Yeah, these are the fibrovascular septae. And there are what? Perinuclear halo or clearing of the cytoplasm. This is very classical of seminoma. Yes, correct. This was a seminoma. Again, we discussed this in class. Okay. AML, APML question was elderly male. Okay. Blast were more than 25%. Okay. So yeah, that is good with history, but it really doesn't make the difference. So question was elderly male. Yes, from elderly male. Let me write it like this. So yeah, I will just edit that subsequently. Elderly male patient. Right? Recurrent infection. Bone marrow aspirate shows 25% blast, right? This was the history given. As below. So what is the translocation, right? Okay. So that is your answer doesn't change, right? So question number 12, seminoma. Embryonal carcinoma, you will see pleomorphic cell, prominent nucleoli, hyperchromasia, then mitosis, gland-like structure. Yolk sac tumor, Schiller-Duell bodies, granulocyte cell, Kohl-Exner bodies, right? Okay, next question. Question 13, histological examination of lung tumor. Histological examination of lung, not tumor, sorry. So histological examination of lung shows, yes, it showed pink frothy material and hemosiderin laden macrophages. So this pink frothy material, what can this be? Pink frothy material will be what? Protein, any protein. So what of the following is the likely, which of the following is not the likely cause? So they have asked which is not the likely cause. Right heart failure, that is the correct answer. In right heart failure, yes, right heart failure, there will be, okay, basically pink frothy material and hemosiderin means what is happening? There is edema in the lung, pulmonary edema is happening. Hemosiderin macrophages will happen due to congestion in the lung, and pink frothy material can be any edema, right? So pulmonary vein obstruction will lead to pulmonary congestion. Protein losing enteropathy will lead to edema anywhere, generalized edema. Hypoalbuminemia, fluid overload also can lead to pulmonary congestion. So in this, best answer is right heart failure. Right heart failure. If the option was left heart failure, then I'll write protein losing enteropathy. Okay. Yes. Protein losing enteropathy. If it was left heart failure, because left heart failure will show this, not right heart failure. Next, question 14. A girl presents with photosensitive skin lesions, BCC on face. So she had photosensitive skin lesion and BCC, both were there. And which of the following abnormality is likely to be seen? So again, we discussed so many times in the class, LRR everywhere, DVT, etc. DNA mismatch repair? No, mismatch repair is HNPCC. This is your photosensitive skin lesions, hyperpigmented lesions. This is your xeroderma pigmentosa, isn't it? And that will be having a NER, nucleotide excision repair defect. Nucleotide excision repair defect, right? Yes. Next, there was an image like this. Identify the following structure, and people said there was a stratified epithelium. Some people told it was definitely transitional as well. Anyway, option given were gallbladder, ureter, trachea, duodenum. So if it was a stratified epithelium, amongst this, only one which will show stratified is what? Ureter. Okay. Yeah, only one which will show stratified epithelium amongst them, ureter. It will be a stratified transitional epithelium actually, right? That is your ureter in this. This is a transitional epithelium. On the top, you are seeing umbrella cells as well, right? These are the umbrella cells on the top layer. So this was your ureter, urinary bladder, whatever was given, right? Next, 16, a child presents with visual disturbance. So child presents with visual disturbance. Then imaging shows supracellular tumor. So imaging showed supracellular tumor. And histopathology shows anucleate squames and wet keratin. What is the likely diagnosis? So anucleate squames, wet keratin can be seen in at supracellular tumor. I'm sure many of you would have diagnosed this based on supracellular. Answer becomes what? Craniopharyngioma. Craniopharyngioma. That is the correct answer here. So supracellular can be even optic nerve glioma sometime, but yes, but not classical. But optic nerve glioma will show what? Rosenthal fiber, and that is nothing but pilocytic astrocytoma. Medulloblastoma will show small round cell tumor, and it will not be supracellular in location. Meningitis, definitely not the answer. Meningitis or meningioma, I do not know what was the given option there. Next question. CD markers can be detected by the following tests. So I think they are given CD markers or malignancies of blood. Basically, they can be detected by the following test. Okay. One more option was a craniopharyngeal cyst. No. So it is a craniopharyngioma. In fact, one more you have to remember. Craniopharyngeal cyst you're telling, right? In fact, one more is gross examination of this craniopharyngioma will show motor oil appearance or machinery oil appearance because it will be very thick and greasy. So we call it motor oil appearance. It will be like your engine oil that we put in bikes and cars, right? So CD markers can be detected. Oh, there was an image. Okay. There was an image of craniopharyngioma. There was an image. Okay, there was one more Ratkes cleft. Okay. Okay. Chalo. We will end up taking that later. I'll change them. Okay. So next is, okay. CD markers can be detected by which of the following? Answer is C, flow cytometry. CD markers can be detected using flow cytometry, isn't it? Yes, CD markers with flow cytometry. Cytogenetics will identify chromosomal abnormalities, which can be done for CML, AML, and myeloid neoplasms. Next generation sequencing can detect almost every abnormality, all mutations, etc. Karyotype is nothing but cytogenetics only. Next, a patient presents with imbalance, vertigo. There was a CP angle mass was seen on imaging. Histological examination shows antennae A areas, antennae B areas with verrucae bodies. See, look at this. In this exam, there were more of descriptive questions. They did not give you the actual image, but they described the image. So it is not just if you had looked at the image, but you should be knowing what exactly is seen in that image, right? Yeah, this is your schwannoma. So antennae A, antennae B area, schwannoma. Next, a young lady presents with jaundice pruritus. Anti-mitochondrial antibodies are elevated. AMA is positive, elevated. Liver biopsy shows lymphocytic and plasma cell infiltrate in the bile duct. They are given, I guess, in bile duct. Yes. So, what is the likely diagnosis? So, likely diagnosis is a primary biliary cirrhosis. So, this yeah, AMA hai, yes, correct. That is why primary biliary cirrhosis, lymphocytic infiltrate in the bile duct. This is called florid duct lesion, and there will also be destruction of the bile duct happening here. Primary biliary cirrhosis, right? Yes. Next. Next is cut section of liver mass shows a central stellate scar. Stellate again star-shaped scar as shown in the image. What is the likely diagnosis? So look at this, such a central stellate scar in a well-defined nodular lesion you are seeing. So yes, such a nodular lesion that is seen, that will be what? So where do you see stellate scar? Stellate scar will be seen in two conditions. In this, answer is focal nodular hyperplasia, FNH, focal nodular hyperplasia. Another condition where you can see fibrolamellar HCC. Grossly, it will be very difficult to distinguish fibrolamellar HCC from focal nodular hyperplasia. Okay. Yeah. So even it could be what? Stellate scar could be seen even in fibrolamellar HCC. Next. A child presents with lens dislocation, tall stature. What gene is likely mutated? Yes, what gene is likely mutated? So simple question. It is, what is that? Yeah, this was your Marfan syndrome, isn't it? Marfan syndrome will be fibrillin, FBN in this fibrillin mutation. Fibrillin mutation. So these were the questions from pathology. If I missed anyone, any question, please tell me, guys. I missed anyone? Yeah, collagen 1A abnormality will be, yes. So there can be collagen 1 abnormality can be Eller deficiency, can be Ehlers-Danlos syndrome, even osteogenesis imperfecta. Yes, correct. Okay. Okay. The question did not mention central stellate scar in what do you call FNH? Yes. No, even in see, Marfan will come in every question. So it is not about FMG. If it is not about the INICT, see, the question had representation from the same diseases keep coming again and again. Obviously, examiner cannot invent new diseases, right? तो वही तो क्वेश्चन पूछेंगे. Okay, no description was there. About what? No description was, okay, only image was given. Okay, only image was given. And there was a central scar seen, right? Okay, is as below. No central scar was mentioned, right? Okay, okay. Thank you. I've just changed it. Okay, yeah. So there were 21 questions from pathology. Yeah. So stellate scar image was there, but no one lesion was there. This image was not there. Of course, yes. So I will not be able to replicate exactly the same image. This is just I googled an image and I've got it. Okay. Any question which I have missed, guys? All that was needed was positive mind? No, you should have read and then positive mind. सिर्फ पॉजिटिव माइंड से काम नहीं चलेगा ना. सो पहले तो कॉन्सेप्ट सही होना चाहिए, देन पॉजिटिव माइंड वुड हैव डन गुड. ओके. Okay, image was a typical stellate scar was given to you. Okay, chalo guys. So if I have not left out any question, if I have left out any question, please let me know them. Any question? I'm just checking. Okay, it was a typical stellate scar image given. Chalo, I'll change the image then. Okay, so we have discussed all the questions of pathology and all the questions were discussed in class. Okay, so nothing, I would say 100 out of 100, all questions were discussed in the classroom here. With your basic understanding and concepts, you could have answered them, right? Okay, guys. So best wishes. I will be ending up the session now.